It's my very great pleasure to introduce our guests for the evening, Dr. Judy Evans and Dr. Susan Schenken. Dr. Evans is a leading consultant in plastic surgery. She was the first woman to gain the fellowship of the Royal College of Surgeons in plastic surgery, and the first woman since the organisation's foundation in 1505 to be appointed Honorary Secretary of the Royal College of Surgeons of Edinburgh. Dr. Evans' career choice was inspired by the late Dr. Gertrude Hertzfield. She was a paediatric surgeon and the first female practicing fellow of the college. Today, Dr. Evans combines practice with teaching and being an examiner for the Royal College of Surgeons of Edinburgh. Dr. Susan Schenken has been working as a clinical academic in geriatric medicine at the University of Edinburgh and NHS Lothian since 2011. She's a senior clinical lecturer and honorary consultant. She's also the NHS Research Scotland Ageing Speciality Lead. So I'm very pleased to welcome our distinguished guests. And I think, as you all know, the theme of the evening is, have times changed enough for women entering and working in the medical profession today, or is there more work to be done? These are just some of the questions we'll be asking tonight. But first, let's find out a little bit about the background of our guests. And I see that we've just been joined by someone else, I think. So welcome. So if I can turn to you, Dr. Evans, and if you don't mind, if I call you Judy. Can you tell us a bit about your path into medicine, please? Did you always want to be a doctor?
No, I didn't want to be a doctor at all. I wanted to be a marine biologist, and I had a very romantic view of probably Jacques Cousteau going off on some wonderful boat, diving in and getting specimens to study. So I did actually do zoology as my first degree. And while I was doing zoology, I gradually came more to animal physiology, and we were at that time looking at the animal studies, which were the precursors to the Louise Brown Test Tube Baby program. And one of the maybe less endearing features of my character is that I'm terribly stubborn. And as a PhD student doing this work on mice, I was told that I couldn't do this on human material because I wasn't medically qualified. I was only a zoologist. And that's always been something when somebody has told me I can't do something because, I'll always try and take the because away. So I actually gave up my research and went and became a doctor with the idea that I would come back into animal physiology, human physiology research, but somewhere along the way that never happened. And they told me that I could never be a surgeon because I was female. So that became the next thing that I felt was a challenge that I had to overcome.
Wow, so that's quite a journey to begin with. So we'll come back to you in a little while and ask about these barriers that seem to have been put in place. If I could turn to you, Dr. Schenken, and if you don't mind, if I call you Susie. What about you? What made you decide that medicine was the career for you? Was there any particular thing that set you off, or anyone that influenced your choice?
Well, I suppose for me, it's probably a more standard thing that many school students will be familiar with. I was at school in Glasgow at Hutchins Grammar School, and well, I think there's a joke that goes along these lines, isn't there? You know, there were two choices of potential careers for somebody who was quite good at exams. It was either medicine or law, you know. And I was good at science, and I enjoyed biology and chemistry and not so much the physics. I was good at exams, and really that was kind of what was an encouraged career from the school, I think. But I was also very lucky. My dad, who I better be nice about because I know he's listening in, was a doctor as well, and seemed to be very happy in the job. I always saw that as an interesting job. He was a clinical chemist, so I saw that there was a big range of different things you could do with medicine. And there were a lot of medics in my family. My great uncle was a GP. And my other great uncle was a psychiatrist. So there were lots of positive role models from medicine. So I think it was just a natural progression from the academic side and an interesting career, and something that was challenging and worthwhile. And all the traditional things you say when you go in for your medical school interviews about wanting to help people and make a difference, but I think they really were motivators for me at the time.
So that sounds like you were getting a very positive news from them about their job and their work, and they weren't trying to put you off or anything. Would that be correct?
Yeah, I think that would be fair. And I think they would have been encouraging whatever I wanted to do, and they certainly were with me and my brother and my sister as well. And we've all taken different routes in life. But I think that I was never discouraged from pursuing anything I wanted to do. And once I decided this was a route I wanted to take, then just went forward and did that. And I think the nice thing about going for a career in medicine is it's very stepwise. You can do different things along the way, but once you make a decision about what you want to do, there is a very clear path towards that.
And a very tough path as well,
Yeah.
I imagine. So now the Edinburgh Jewish Cultural Centre on International Women's Day inaugurated International Jewish Woman of the Year, along with the Royal College of Surgeons, and they gave a posthumous award to Dr. Gertrude Hertzfield. Now, Judy, I understand you were inspired by the work of Gertrude Hertzfield, affectionately known as Gertie, I believe. Tell us a bit about Dr. Gertrude Hertzfield.
Well, of course, for me, I was the first person in my family, and there were no role models in London, no female role models. But as well as that, there was still the hostility to women deciding to do surgery. And in fact, I did have to go off to Hong Kong to do a few years because I couldn't get a place as a woman to study to be a surgeon in London. And I started then to take the surgical exams. I had no contact with Edinburgh whatsoever, but periodically the different colleges would set their exams on different days, and I took the exam in Edinburgh and passed eventually, not first time, I have to say. And suddenly I realized that there was a different attitude towards women wanting to do surgery via the Edinburgh College. And we were not insulted when we came for the exam. And I did go and turn up for the exam in London pregnant. And I was asked, what was I doing in a serious surgical exam looking like that? But in Edinburgh, I was always treated with courtesy, and the questions were tough and hard, but it was fair. And then as I began my surgical career, I found out more and more about the long history of women in surgery in Edinburgh. And everything I found out was very encouraging. And of course, we talk about the people, the Battle of the Royal College, it was called, in 1871, when
This
people
was
came over.
The famous 7, I think.
Yes, that's right. When the women came along to take their exam, and they were pelted with cabbages by male medical students who thought this was shocking that they were there. And a sheep was allowed into the exam room. And the examiner was very sensible. He just said, leave it. It's obviously got more sense than the lads who've sent it in here. And so the Edinburgh 7 actually took their exams, but they were not allowed to receive their diplomas. So at that time, Edinburgh was beginning to open the doors, but it didn't completely open them. And it was later when Gertrude came along that she was the first person not only to qualify as a doctor, but to go on and qualify as a surgeon and practice as such. The Edinburgh Seven had to go off and get qualifications elsewhere, or were not really allowed to work as doctors, would do other things. But really, it was just that the first door was opened by Gertrude. Now, one of the problems with surgery is always in the past that general surgery has been thought of as being the main thing. And I'm sure that there were people along the way when Gertrude started doing pediatric surgery, that they would have seen that as something that was, well, that's okay for women to do, you know. Basically, I think she dealt with that as well. So pediatric surgery in many ways is very much more difficult than adult surgery, because they're not just little adults. They have very different physiology and very different problems. So congenital things manifesting in childhood as well. So she really was a superstar.
Right, and I suppose in pediatrics, children are still growing, and that must be an element in surgery.
Yeah, definitely. Definitely. And they're tiny to begin with when you're operating on them.
With babies, I'm sure. But what I can't understand, just going back, you know, why initially they felt that women couldn't be surgeons. What was that all about?
Well, there was a very interesting discussion when, I think it was around the Edinburgh Seven, when, of course, the first people who went to medical school were quite wealthy, and their fathers paid for them to attend the medical school, and therefore they were regarded as ladies. And the argument in the Royal Colleges was, we cannot expose ladies to the sort of horror that a male surgeon would see. And somebody came up with the answer, why ever not? Because the nurses are female and they deal with the everyday horror of war wounds and sepsis and all these sorts of things. But somehow or other, the truth of that argument didn't come home. It just stayed as a prejudice for a very long time.
Mm. I mean, did the First World War change things? Because, you know, with the women's hospitals and Elsie Ingalls and that whole aspect.
Yeah, all that happened, but like with so many occupations, it went back a few years after the wars.
Right.
But I think if I can just pick up on that, David, because I think the same thing carries on now, doesn't it? That there are careers within medicine, within surgery, that are seen as more female careers, and there's a big sex divide in lots of these things, aren't there, Judy? That from starting in medical school, and nowadays it's 60% female when you start in medical school, but it's by the time you get to being a consultant, then probably in medical specialties like mine, there may be 25-30% female at the consultant level, but probably more like 10% in the surgical specialties. And even within those specialties, in medicine, there's many more doctors, many more consultants female consultants in specialties like mine, like geriatric medicine, pediatrics, general practice, palliative care, and many fewer in cardiology, respiratory medicine, and so on. The balance is slowly redressing. The percentages are coming up in the trainees, but still, as you become more senior, they're going down. So I think it's there's still a bit of a way to go.
So Susie, when you were training, were you pushed in any particular direction or discouraged from going in?
I don't think pushed would be the right word. I mean, I think Hutchie instills in you this wanting to always, you know,
you don't believe in bus queues.
Hard, yeah. So I did finished my degree, and I'd done did okay in my exams, and went from, I preferred medicine rather than surgery, and people have their own preferences to that. But I didn't know what branch of that I wanted to do, so I did a general training rotation in Oxford for 2 years, and I was the only person there that wasn't from Oxford or London or Cambridge.
Right.
Nobody could understand a word I said, but down there I did a nice rotation through lots of different things, and I found that I liked everything, and that has been a bit of a problem through my whole career, is that I kind of like everything that I do, and so I really couldn't decide what specialty to do. So I thought that I was quite interested in the brain and how it worked. So I thought maybe neurology. So I went to London for 6 months to London to do a neurology job to see what I was interested in. That was neurology is quite a male-dominated specialty, and it felt very biased toward diagnostics and a bit less about the whole person and what would happen with them after they had a diagnosis and what would happen after that. So and at that time I met Jonathan, and we decided to come back up to Edinburgh to get married. And I was looking for a job to do when I came back up to Edinburgh, and applied for a job in geriatric medicine. And it was in that job where I realised that you could do a bit of everything. So that was the geriatrics is the kind of the last of the general physicianly specialties where you can do you become a bit of a generalist, but a specialist in complexity and frailty and people with multiple conditions. And I was really attracted to that, and very much to the consultants that I worked with at that time, which was a female role model, I guess, Nikki College, who I worked with, and David Grant, who many of you will know, and Trish Cantley and Joan Whitwell. And so I saw some strong female role models and some very interesting clinical complexity, and I just thought that it just felt like the right fit for me.
Yeah, and interesting, I suppose, in geriatrics, the study of the brain is important as well. So,
yes, and a research interest very much to do with cognitive and dementia and delirium. So I've come full circle that way, which has been nice.
Absolutely. So I mean, it sounds like your schooling gave you quite a bit of confidence, and Judy, maybe the same with you. So both, did you find in your career progression that you had to be quite strong in saying, yes, I can do this, or I'm going to take these exams and go further and further, because you both become consultants? And is it
all the time?
Yep. Sorry, Karen.
All the time for me. The women had to do better than the men.
Yeah.
It varied, I think. And I think, well, one of my mentors and bosses, Ian Deary, who's a professor of psychology here in Edinburgh, I've talked to him a few times about differences between men and women, and he thinks that individual differences are more important than sex differences. And I guess that there's a bit of both, isn't there? There's some generic things that are different between men and women, but there's some things that are just different between you and me, and it doesn't matter whether we're men and women. So we need to understand that some people prefer some things, and that's totally fine, and some things are institutional, and we need to get over that.
So what sort of, Dr. Judy, what sort of obstacles were put in your way? I mean, did you go for interviews or boards and find, sort of prejudice there?
Yeah. So when I got my consultant job, I'd been working in that city for 4 years as the senior registrar, and everybody knew me. And I had 2 children, and this was at a time when it was illegal to ask discriminatory questions at interview. The first question at my interview was, I know I'm not really supposed to ask you this, but if we give you this job, how will you cope with the childcare? And my answer was, well, exactly the same as I've done for the last 4 years, and you've never noticed. But it was still there. And I mean, going back, when I was the first female surgical trainee in one hospital, I love telling this story. I went into the theatre and I was faced with 2 doors. And one said nurses and one said doctors. So I went into the doctor's changing room, which of course had urinals and male scrubs. So I went off and I got some female things and went through the nurse's route the first time. But the next week I came back and I got an old bra and I left it hanging on a peg in the changing room. And, you know, I don't know how long it lasted there, but the following week when I came back, the doors had been changed to male and female. So these were the little things that were, this was in the 80s. And I think when I'm talking to medical students, they don't realize how much it has changed in 25 or 30 years. And that's been something where I expect for you, Susie, it was better 10 years after me or whenever it was.
Yeah, absolutely. No, I graduated in 94, so I'm from the 90s, and I'm a medical student in the late 80s, early 90s. And
yeah,
I don't remember it ever being an issue, really. I mean, I think that maybe for some people it was more, and some people were put in difficult situations, but certainly personally, I never found myself in that sort of situation. But I guess I wasn't trying to do surgical specialties, you know. So there might have still, there certainly still were a lot of male, you know, these sort of traditional attitudes of old-fashioned ward rounds with lots of people round the bed and turning questions at you and you know, death by humiliation and that sort of thing.
Yes.
Certainly when I was a student, but I don't really remember it being a gender-based discrimination.
Mm-hmm. And I mean, of course, diversity is a big issue in society generally and in the NHS. Do you think things are changing in terms of our attitude to people of different ethnicity and different faiths? Do you think that in the medical profession, the NHS, for example, are becoming much more aware and sensitive to that?
6 months ago, I would probably have said not enough, but I think the differences in ethnic minorities succumbing and having greater problems with COVID have made everybody start thinking about this in a different way.
Yeah, I'd agree, and I think it has come a long way, and there's both the reality of the progress that's been made, and there's also a lot more awareness of everything, isn't there? So I was at a conference last October in Krakow, when we were a geriatric medicine conference, and at the closing ceremony, some people stood up on the stage, and the very first thing that people said was, "They're all men."
Yeah.
People notice it now, they really do. Yeah. And I think people who are organising these conferences, and the people on the stage as well, you could almost see them noticing it as they stood there. And people are much more aware about the importance of showing diversity and encouraging people to come on. And some people would argue maybe it's tokenism sometimes, but I think it's really important that people say you can't be what you can't see, can you? So we need to put women on these panels. We need to put people with ethnic diversity are seen in places, and we bring our junior colleagues up to showcase their talents, to make sure that everyone gets seen, so that people can understand that they can do whatever they want. I think that's there are organisations that are trying to support that, Dina Swan and so on, and I think that they are really important.
So, I mean, interesting, we're beginning to talk about the current situation and coronavirus, and I think everybody would agree that the past few months have been extraordinary times due to the pandemic. What I'd be interested for you to talk about now is, you know, how is that? First of all, how has it affected women in the medical profession, and also people training and your patients, your clients, if you like. Susie, what about you? I mean, care homes is obviously a very big issue.
Yeah, so I don't know if everybody knows, but so my clinical work is mostly in the Royal Infirmary, which is a general hospital, and I look after inpatients there who have the range of issues that older people tend to come into hospital with, which is generally falls, confusion called delirium, or other issues like that, very medical issues. But the wider group that I work with work within the hospital and in the community, and my research is now starting to develop into exploring how people move between hospitals and care homes and the aspects that influence that. And I've got links with quite a lot of the local care homes here in Edinburgh. I mean, I think it has impacted on everybody, and not just the patients or the residents in the care homes and people in hospital too, but their wider families. And I think everybody on the call tonight probably can feel how difficult it's been not to get to know our own families, and anybody who has loved ones in hospital or in care homes and haven't been able to access them and haven't been able to communicate with them in the same way as you normally would. It's been incredibly difficult. And the technologies that young people think are second nature to them, and they're able to keep communication. And there's been some great things, FaceTiming from hospital and so on. But if you've got a 94-year-old with dementia and hearing difficulties, and nobody's brought in their batteries into the hospital or the charger for their hearing aid, then the communication becomes incredibly difficult. And I think that there's been the medical side of that, there's been the communication side of that, and then there's been this sort of long-term loneliness and sadness for everybody involved as well.
And of course, one of the main controversies about care homes at the moment is the idea that to clear space in hospitals, older people were perhaps pushed out to care homes before they were ready or before they were tested. And I'm sure that, that's going to be explored at a later date through surveys or whatever. But do you think care homes have been kind of overwhelmed by taking in more people?
I could be a little bit cheeky, David, and say you've strayed a little bit far away from the brief of this evening.
Oh, sorry. Sorry, I'm not trying to push you into giving, political answers and things.
No. I think it is difficult, and I think but I think that where we are now is quite different from where we were then when it all started, and the information we have now and the facilities we have now are different from what we had when things started. There are a lot of questions to answer, and I think that we shouldn't jump to conclusions without knowing all the sides of all the facts. But I would certainly agree that there's nobody wanted to be where we are now.
Yeah. I mean, I think that seems to be the thing, that it's all much more complicated than perhaps we get to understand through the news and current affairs, and also through the answers we get from politicians. So I think that's very difficult.
But to take it back to the idea about gender differences, if you think about the care home sector, the people who work in care homes are predominantly female. And the people who are making decisions and are in higher levels of management are more predominantly male. So I think we have to think carefully about the impact that can have on what decisions people can make, and the security that people who work in these industries can have. And I think we have to have your eyes open to some of the differences there.
Mm. And turning to you, Judy, in your work, how has the pandemic affected both your work as a surgeon, but also your work in the field of training?
Well, in terms of surgery, people who have had elective procedures have just been disallowed during this time. So everything was cancelled. Now, the biggest problem has, of course, been the workforce. And what are we going to do about people who were on 6-month contracts or 6-month rotations before they moved on to another specialty, perhaps? And some of the people would require to take an exam and to pass an exam before they could progress. and all the exams had to be cancelled as well. I was a day away from flying to Delhi to do the exam when the Indian government revoked all the visas. They didn't want us, so we couldn't go. But what we've been doing a lot has been looking at our exams and seeing how we can take our exams forward online. Now, we do something called an OSCE, which is a very tightly time-controlled interview with candidate and surgeon, or with candidate and an actor who is portraying a communication issue, and the surgeon is listening and watching and giving the candidate marks on that sort of interaction. And one of the things, of course, that has been very important in terms of making surgeons more whole person type of doctors has been to introduce communication as an important skill to teach, and to have our trainees and some of our senior people learn that communication is all important. So this is now 25% of our exam. So we've been working on ways of how we can deliver exams remotely. And I would say we've got to the point where in surgical exams, we can probably do 75% of the exam remotely now. And I've been working with a small team, and we've developed a training course which will run for the first time the first weekend in July, so not very long now, where we're looking at the response of the candidates to how we are teaching them the skills that they will need to pass an exam, which will then facilitate them going on to be surgeons. So it's been huge.
Right. And the practical side of the training, and that's presumably been...
Well, it's learning all the new skills. So what's happened to surgical trainees who have been in departments where they would normally have been doing elective surgery? So cold orthopedics being a very good example. If they were predominantly doing joint replacements, all of that would have been stopped. Now, some of those candidates, or some of those juniors, would have been redeployed to A&E or to acute medical wards, or even to ICU. Now, if they were deployed in that way, they would have become fantastic at learning how to put drips, learning how to intubate patients, all these sorts of things, which will make them very good doctors into the future, better doctors, but not necessarily more experienced surgeons. So we've had to be looking at that gap, that people haven't had the opportunity to spend a year getting 100 cases of a surgical diagnosis under their belt, but we shouldn't actually be judging them as any less good because they've got much better alternative skills.
Right.
But the other thing I think you have to think about as well with thinking about the gender issues again is some of these things, because people have been put in places they weren't expecting to be and done things on different rotations and perhaps in different hospitals and different places, then people who have caring responsibilities, it's very difficult for folk to plan that. And people who work flexibly or less than full time, as I've done most of my career, then if somebody says, actually, you need to work, you work certain days, but maybe it doesn't work for the new service you've moved into to work those days. And maybe, you know, if you've got childcare and suddenly the schools, you don't know whether they're going back or they're not going back, how do you plan for your rotation that's going to happen in August? So I think that there are some very big picture things that really are important that the people who are making decisions about redeploying people and thinking what happens have to think about the wider picture and how it impacts on people's families. And two doctor families, of course, very difficult for them.
Yeah.
Yeah. Yes, I always get that impression from people I know that are studying or pursuing medicine, that because of rotation and having to move to different hospitals in different areas, it must be quite tough to juggle that with your personal or family life, whatever gender you are.
Definitely.
Why so many female doctors marry male doctors?
But it's probably easier if you marry somebody who's not a doctor.
Yes.
Having been in
Uh,
that position.
so interestingly, what seems to be quite positive in our discussion tonight is that things, have moved on, and there's better equality. But for women in the medical profession, what still needs to be done? What could improve things? Is there anything?
I think for me, the thing, Judy and I were talking about this earlier, is the thing that's helped the most to raise awareness has actually been male colleagues standing up to speak to promote their female colleagues. It's called, some people refer to it as leaning in. When my male colleagues have said, no, actually, we need a woman on this panel, or we need a woman to stand first, or can so-and-so be the spokesperson, because traditionally women in a big group situation will often listen before they speak, and the men may be up speaking first. And sometimes it requires the men in the room to notice that, and to help people to make their voices heard when they don't want to. And I think those of us that are further on in our careers and can support other people need to shine a light on that, and to really support and make sure those things don't happen going forward, and just to try and help that to become a bit more equal.
Thank you, Susie. Judy, what do you think?
Well, I would agree with that. And if you look particularly at what we now call less than full-time training, while that originally was thought of as, an easy way for girls to take time off to have a baby, I think the development of the realization that less than full-time training can be very positive for men and women. So we've had lots of examples of international sportsmen who have wanted to take less than full-time training, and they haven't had to make the decision then between their sport and medicine. So to have men doing that has been great. And also, as Susie says, to have men who recognize that these things are positive rather than just negative.
I guess in a way the pandemic has made us think of different working methods. Much more people are working from home instead of going into the office, lots of different things like that, and the way technology has helped that. So perhaps one of the good things that will come out of this is that we think differently about working routines and how we work and how we can work. We're going to invite questions from the audience in a few minutes, and as I said before, if you have got a question, if you'd like to write it on the chat facility, you can put your questions to our doctors. But just a final question for me to Judy and Susie. If someone you knew was coming into the medical profession or planning a career in medicine, what advice would you give?
Well, I have 3 kids who are junior doctors. Well, one is now a consultant. So we actually tried to put them off, and we felt that by showing them the reality of how tough it was, they would then make decisions for themselves. And if they were people who would be put off easily, then it wouldn't be for them. And I've always run a program of work experience where I will have someone with me who shadows me for a week. And these people, almost all of them have gone on to do medicine, but 1 or 2 of them have said they've been very grateful. They realized that it wasn't for them. So I would say to people, go and find out if it's the right thing for you. If you're prepared to be tough about it, it's actually the best career you could possibly have. Thank
you. Susie, what do you think?
Yes, I'm in a similar position. A few years out of state, so my son Sam is currently applying for medicine and has got a place to start studying in this September, hopefully, if all goes well. So and I don't think I didn't manage to put him, no, I didn't try to put him off actually. I mean, I think it's, you know, it's a testament to Judy and hopefully to the way I work as well, is that our children have seen that we enjoy our jobs. And I think that there are people in medicine who don't enjoy it, and you know, it's a tough job. It can be difficult, especially if you don't find a specialty that suits you. So I think that the great thing about medicine is there's a huge diversity in it. And I think I totally agree that trying it out and people getting work experience is really important. But if you get work experience in pediatric surgery, you may actually still like a career in radiology. Or if you get experience in clinical biochemistry and you don't like the lab work, you might like a cardiology job. So I think people getting some diversity of experience and understanding the range that there is and the possibilities. And that medicine isn't the only way of doing healthcare. There's nursing and occupational therapy and physiotherapy, and we much more work as a team. And as you're saying, what we've learned through COVID is the power of working in different ways, and that data science is going to be a big part of health going forward. So even people who have a sort of computer interest can move into the sort of healthcare world too. And I think there's going to be a real need for that in the future. So, but I think the advice would be to talk to lots of people, see the diversity, get some experience, but if you want to do it, then absolutely it's a great career.
Thank you very